So MIBG therapy is for pheochromocytomas and paragangliomas. And we've just recently managed to get public funding with the help of Rachelle for MIBG treatment. So it's a fairly old treatment in nuclear medicine, but it's fairly new to New Zealand. So it's good that it is an option for patients, and they can, I'll tell you all about it in a second, once I've shared my screen. Understanding MIBG therapy. So let's start at the very beginning. What are pheochromocytomas and paragangliomas? Now, these are a group of cancers which develop from your sympathetic chain. I don't know if you can see my cursor, but your sympathetic chain runs down your spine, okay, from the top to the bottom. And they also develop from the adrenal cortex. So just above your kidneys is a little gland called an adrenal gland, and that's where these cancers start. So they're very different to your typical neuroendocrine tumors. They're also classified as neuroendocrine tumors, but they come from a slightly different type of cell, and we treat them differently. So if they come from the sympathetic chain, which is this chain that's along the vertebral column, it's called a paraganglioma. And if it originates in your adrenal cortex, which is over there, it's called a pheochromocytoma. So that's in very simple terms. The cells that these cancers come from are called chromaffin cells, and they've got some norepinephrine, or like it's almost like an adrenaline inside them. So that's kind of where these cells originate. And that's why this sympathetic chain helps us with fight and flight reactions. You know, when you get a big fright, your heart starts beating and you start sweating, and your blood pressure might go up a bit. So that's where these cells originate from, and that's why they've got some adrenaline in them. So when you have this fight and flight reaction, they can release it. So they've got adrenaline in them, and some patients actually are quite symptomatic from these tumors. So they might cause you to have an increase in blood pressure, might cause some heart palpitations, and might make you feel a bit sweaty. And that's when you say you've got what we call a functional tumor. Your tumor is secreting a certain type of hormone, and it's causing these issues for you. And that's typical of your paraganglioma and your pheochromocytoma type of cancer cell. Some of them don't secrete these hormones. Some of them don't create the blood pressure problems or the palpitations or the sweatiness. Then we call them non-functional. So you can have two different groups. Right. And very importantly, if you've been diagnosed with a pheochromocytoma or a paraganglioma, there may be a genetic association. So that just means that if your mom or your gran or your granddad had a pheochromocytoma, they may have passed on the gene, and you may pass on a gene to your children. So that's why you have to be tested and go for genetic testing, specifically when you have been diagnosed with a pheochromocytoma or paraganglioma. So you'll hear your doctor perhaps asking you to go for a genetic test. So what does the term metastatic mean? I'm sure you all know, but that is when a tumor has spread from where it started to other areas of your body. Could be the lung, could be the liver, could be somewhere in the bone or lymph nodes in your tummy, or to bones. That's where the tumor is spread to, and that's where we come in with our targeted treatments. It's because we can't remove the tumor with surgery because it's spread to other areas of your body. So that's why we need to target it or try and treat it in a different way. So what is MIBG? So you can probably guess what MIBG is already. Well, it has a very long name. It's called meta-iodobenzyl-guanidine. So that's just because we like long names in nuclear medicine, but we'll just call it MIBG. And remember this little guy, norepinephrine, or the adrenaline? So MIBG is a very good mimicker of norepinephrine. Okay, so if we go back to, remember these figures? We used to use them at school a lot, quite. So they look exactly the same. They're very similar in their shape and in their configuration. So when the cell thinks about norepinephrine, it wouldn't really know the difference between the MIBG or the norepinephrine because they've got the same structure. And then what we do is we put a little radioactive particle onto the MIBG, and then that allows us to target the cells in the body. All right, now how do we do that? So this is a very complicated slide, but if you have a look at this, this is the pathway that norepinephrine gets into cells, okay? So it uses the specific norepinephrine transporter. These are all these little blue triangles. You can use what we call a VMAT transporter. It can be taken in with calcium. And if we look at the little triangles, for each triangle, there's an MIBG particle. So the MIBG mimics these little triangles. So the cell can't recognize, the cell can't tell the difference. And that is how, when we tag it with radiation, we can take the radiation into the cell. So that's how we trick the cell, and that's how we get the radiation into that specific tumor cell. So slightly different mechanism to what we use when we use PRRT. We use the noradrenaline way, okay? Now, that then allows us, all of these areas where there are metastases or where the tumor is spread to, it allows us to track and deliver the radiation to those cells so we can get to those metastases. Now, there are two different, just to make it a little bit more complicated, there are two different types of isotope or radioactivity that we can link with MIBG. So the one is an I123 MIBG. The other one is I131 MIBG. And I'll tell you what these two are used for. The one with a 123 is used for imaging, okay? Not on a PET camera, on a slightly different camera in a normal nuclear medicine department called a SPECT camera. So that's what we do to take an image. And then, it goes into the cell exactly the same way because it's tagged to MIBG. The other one is the I131 MIBG, and that is what we use for treatment. So again, we've got this sort of relationship between imaging and treatment. Okay, so now we know how it gets into the cell, we know we can image it, and we know we can treat. So let's have a look at how do we do our MIBG imaging, okay, because it is a little bit different. So that's the 1, 2, 3. And I'm very glad Andrew has given us a physics tutorial already, but the I123 MIBG has got the particle we need for imaging. So that's the gamma particle, okay? It doesn't have anything else. It's not good for anything else. It's only good to image. So it'll tell us where your tumor is and where it's spread to. So when we do these images, we don't go for a PET scan because it won't pick it up. It's got a gamma particle. You will go to the nuclear medicine department, and it's on a different type of general nuclear medicine camera called a SPECT CT camera, also a fancy name, but it's just a special camera that can pick up that gamma ray. And that can then produce an MIBG image. Okay, so here I've got a picture. This is a person from the front, and this is a person from the back, and these are normal MIBG pictures. All right, so you can see a little bit of uptake in salivary glands. So that's where MIBG goes to. Your thyroid, okay. Your heart obviously needs a bit of uses a bit of noradrenaline because that's how it beats. Your liver, because that's where noradrenaline gets broken down. And then your bladder, okay. And these are just muscles. So that's a normal scan. Okay, so the imaging, we use the I123. We then get an image. What do I need to expect when I go for MIBG imaging. Where is it done? In New Zealand. Main centres that MIBG imaging can be done would be Auckland, Wellington, and Christchurch. So those are the big hospitals where MIBG imaging can be done. What does it entail? So it entails a tiny injection into a vein, and that injection is usually given to you on a Thursday. Now you say, why not on a Monday or a Tuesday or a Wednesday? Specifically on a Thursday, because MIBG gets flown all the way from Australia, and the only time that they can deliver it for us, they make it once a week, is on a Thursday evening. That's when New Zealand delivery happens. And no matter what we do, we can't change that. So it'll always be on a Thursday. And then you need to wait for the MIBG to be taken up by the tumor cells. So it'll be an overnighter. And then the next day, you'll get your MIBG imaging done. So it's slightly different to when you just go for a PET scan, you get an injection, and then you have your image. Okay. How do you prepare for an MIBG scan? So there is some preparation involved. Do you remember the picture I showed you with the thyroid? There we go. There's your thyroid. So we don't necessarily want the MIBG to go to the thyroid, okay? Because let's see how the thyroid lights up quite a bit, and some of the iodine can break free and can go to the thyroid and can actually cause some thyroid damage. So what we like to do is we want to block your thyroid. So we'll give you a little bottle with some solution called Lugol's iodine, and that's you take two drops 1 day before and for 2 days afterwards, and that just blocks the MIBG from going to the thyroid. Okay, so that's all we ask you to do. And then there are quite a few medications that interfere with MIBG uptake. There's a long list, okay? So your doctor will go through the whole list and tick off which medications you're on and which you may have to stop before you come to us for an MIBG scan. Okay. Why do we need an MIBG scan? So why do the scan? So this is a patient who's had an MIBG scan. I've shown you what is normal. So these little areas over there in the neck, that's in the liver, and these are in the abdomen, and there's some little spots in bone, as you can see here. So we need to know, is there MIBG uptake? Is your tumor taking up MIBG, yes or no? We want to see where the disease is. Where in your body is it? Where has it spread to? Because you can see very small tumor deposits. And this also helps us plan the treatments. Okay, very much like we do with PRRT. So what if my tumor doesn't take up MIBG? What do I do then? Well, that may be the case, okay, but some of you have had a GAT8 PET as well, because some of these tumors express those somatostatin receptors, and if it predominantly expresses the somatostatin receptors and not the MIBG, you might be offered PRRT. And I know that some patients have paragangliomas and pheochromocytomas, and we've treated them with PRRT. There may be a case that the tumor is very well visualized on the MIBG scan, but definitely not on the GAT8 PET. You can see that there. You can't really see the tumor. So then we would rather target the tumor with MIBG, okay? It might be a case that you need a combination of the two treatments. You may come for PRRT, and then there's some areas which you need some MIBG for, or vice versa. So you can see over here, this patient, the lesion in the hip over here is not very intense, the uptake on the MIBG, but much better on the PRRT. So you may end up having a combination of the two treatments. Okay. So the treatment. So how does the treatment work? So it's done with I131 MIBG. So that's the second radioactive particle that we can label MIBG with. Again, physics. It has a beta particle. So the beta particle is the particle that causes damage. All right? It causes damage to a very small area, about 2 millimeters. So an alpha can't travel 2 millimeters. It's much, much shorter than that. But the beta can travel approximately 2 millimeters. And then it also has, so that's what we use for the treatment. So there we go. That's the treatment. So we can target those tumors in the body, and the tumor, the target, the beta particle, because it can only travel 2 millimeters, it's very, very specific to those little spots that we want to treat. But it also has a gamma ray. So the one we treat with has both. It's got the beta and the gamma. And what do we like gammas? We want to image. So we can do a post-treatment scan after we've treated you with MIBG, which mimics and should be the same as your diagnostic MIBG scan that you had, the I123 scan. So very similar concept to PRRT, but working in a very different way or targeting a very different type of cell. What do we expect when we do MIBG therapy? So where is MIBG therapy done? It's done in Auckland and it is funded. It's done through an infusion. So you get the MIBG is placed in a drip and that goes into a vein and it's delivered that way. The treatment is usually given on the Friday, always a Friday, because of how they make it and the times that they fly it through to us. So they'll deliver it on the Thursday evening, but we don't want to get you into hospital to give you the treatment on a Thursday evening. We want to give it to you on the Friday morning. The problem with MIBG therapy, and I'll get to that in a minute, I'll extrapolate, I'll sort of expand on that, but you'll get your treatment on the Friday, then you have to be in hospital, can't go home the same day, on the Saturday, the Sunday, the Monday, and perhaps even the Tuesday. So it's a much longer admission than for PRRT. PRRT, you can go home the same day, not with I131 MIBG. Okay, we'll get to that in a second, I'll explain. Preparation, again, you need to block your thyroid because we don't want the treatment to damage the thyroid gland. And for that, you need iodine again, the Lugol's iodine drops, but you have to take it for a little bit longer. So for 3 days before and 15 days after. So it's a longer because that's the treatment. You need to stop certain medications like you would have to for the scan. And then there may be some medications that you may have to start. Okay. And that's usually a little tablet for blood pressure because sometimes MIBG can cause this noradrenaline and adrenaline to be released from the cells when we treat. And what does that do? That can push up your blood pressure. And sometimes that pushing up of the blood pressure can be quite dangerous. So we need to put you on something to stop that from happening. So Veronica, our endocrinologist on the team, you've probably all met her, but she will be the one who'll be looking after you and prescribing the extra blood pressure medication when you come for MIBG therapy. So how about this admission process? Why do I need to be in hospital for 1, 2, 3, 4, 5 whole days? And it's because I131 has got a long half-life. So a half-life just means for how long it takes for a radioactive particle to become half of its strength, if I can put it that way in very simple terms. So it takes 8 days, okay, for it to halve. So 16 days for 2 half-lives. So it hangs around for a very long time, much longer than the, and it's also got a gamma ray, which is quite intense and quite strong. So it's slightly different from PRRT, where the gamma ray isn't that strong, so we can send you home. But this gamma ray is quite strong and can cause quite a bit of damage. So we keep patients in isolation for longer until that's gamma ray until you're safe to go out into public. So once the I131 MIBG has gone to the tumor areas in the body, so there you can see there, and this patient's got some disease in his hip and in his pelvis. So it gets excreted. The stuff that doesn't go to the tumor gets excreted via your bladder, gets excreted via your sweat glands, and it gets excreted via your saliva. So that's how your body can get rid of it, okay? And your body gets rid of it, and it decays, and those two together, usually patients, after about 5 days, they're safe to go out into the public. So when you come in for treatment, you'll be in a room, in an isolation room. So it's the same rooms as we do the PRRT treatment in. It's got a separate toilet, the room with a window. You'll have everything you need, but you have to stay inside the room. And the nursing staff that look after you when you have MIBG, they can't spend a lot of time with you in the room chatting away and, sort of like you do with PRRT. They need to spend not a lot of time in the room because that will protect them from the radiation. So they'll come in, they'll do what they need to do, and the rest of the stuff they'll do at a distance if they can. They'll keep a distance. So if they want to come and say hi, how are you? They'll stick their head around the door. They won't come into the room and sit next to you. And we've got some lead shielding. So they stand behind lead shields, and they can then, sort of chat to you, or anyone can chat to you. It's just as an extra protection from that radiation that gets released from the tumor cells. But it's very important to know that your medical care will always be more important than being radioactive. So although we have these precautions for radiation in terms of nursing staff, if you don't need someone by your side 24/7, that person will, come in and out and do their bits. But if you do need medical care and you need it for a longer period, that comes first, and you will get the treatment you need. So it's not a case of you're radioactive and no doctor will come near you. Categorically not. It's just we try and keep the radiation doses to staff as low as possible. So if it's not necessary for someone to, come close to you, they probably won't. So during your admission, you can imagine it's 5 days? So you have to bring some entertainment. You can bring anything you like. You can bring any form of device. So cell phone, laptop, iPad, lots of books to read, hobbies, knitting, whatever you like, and snacks. Any type of snack you can bring. We ask you to have a daily shower. And that reason is because, remember, I showed you the picture where the MIBG gets excreted by your sweat glands and things. So that brings rinses the radiation off your body surfaces, and also, sort of brings your radiation levels down. Your meals will be delivered to you at the door of the hospital room, so that the staff won't come into your room. They'll leave it there, very much like COVID, when we had that isolation period. Any form of rubbish or any soiled linen, etc., must go into a dedicated bag, because that'll be slightly radioactive, in your room, in the bag, and the medical physicist will deal with that. You don't have to worry about that. Visitors, you can definitely have visitors, probably not on the first day, but your visitors will come say hi. They can come say hi for a short time. They come say hi at the door, and so will the doctors looking after you. They'll pop their heads around and say, are you good? Are you good? Do you need anything? If you don't, then we're all good. And you must remember that everything you take into that room must stay with you in that room until you leave the hospital. Okay. So going home, how do you go home? We've got Alan, our medical physicist. So he'll come and he'll take some radiation measurements and to make sure that you are safe to be discharged into public. He'll give you some advice, some radiation protection advice, which you'll get, when during your admission. And that's very similar to what we do with PRRT. And you then also go downstairs to the nuclear medicine department and have your post-treatment scan, and then also your post-treatment consultation where the doctors will go through your scans with you, also give you your dates for the next treatment, make sure you're well. Side effects, generally, MIBG is quite well tolerated. Patients don't really get very sick, but you may have a little bit of nausea. We'll give you tablets for that. Some patients get a raised blood pressure because of that release of that hormone. In a very small percentage of patients, that blood pressure may get raised to such an extent that you need an ICU admission. It's in less than 1% of patients, so it's really rare. But we do have a full pathway at Auckland City Hospital so that you can go to ICU if you need the care there, and they've got everything. There's a whole process and pathway to follow then. You can get a reduction in your blood count, so that's why we monitor your bloods before and after each cycle. Your thyroid gland, we need to monitor that that's working well. Salivary glands, you saw the saliva. Sometimes your salivary glands can be a little bit affected, but patients don't generally notice that too much. And then, yes, one could develop other malignancies from the radiation treatment. It has been reported, but very difficult to categorize or to, to say an exact percentage, because MIBG therapy is usually given down the track as a last resort, and it may have been any of the other therapies previously that could have caused a cancer as well. So very difficult to put a figure to that. So the key points are we do MIBG imaging. We need an image to see where the cancer is and does it have MIBG uptake. We can then target the cancers with radiation, and it's generally well tolerated, but you have to be in hospital and admitted for at least 5 days after the treatment.